Hi everyone, and welcome. It's great to have you all here from all around the world. I'm Ryoungwoo, the clinical research lead at Coreline Soft, and I'm really excited to host today's webinar. Did you know that today, first day of August, is World Lung Cancer Day? It is a privilege to host and moderate this kind of meaningful webinar on this special day. Temple Lung Center is the leading thoracic center located in the heart of Philadelphia. It is a great honor having Temple Lung Center experts here today. Today's event is a collaboration between Temple Lung Center and Coreline Soft. We are here to highlight Temple's leadership in lung cancer screening and how they are using our AI software, AVIEW, in their real clinical practice. Dr. Stefan Dachert will talk about why AI is becoming so important in lung cancer screening, especially when it comes to detecting COPD. In our second session, you'll hear from Jiwan Kwak, director at Coreline, who will walk us through how AV works in real clinical settings. He'll cover some of our FDA-cleared algorithms and key features such as automated nodule detection, longitudinal tracking, and emphysema scoring with real clinical cases. After that, Dr. Criner, a leading pulmonologist at Temple and a longtime user of AVIEW, will join us to share how Coreline's AI is being used day by day at Temple. He'll talk about its role in detecting incidental findings and what kind of clinical impact it's had so far. We'll then move to a panel discussion with Dr. Criner, Dr. Dachert, Melissa Liverpool, who is a nurse navigator and leads the Temple Healthy Chest Initiative, and myself, both as a clinician and an AI developer. Together, we'll look at how things have changed from pre-AI era to now, and where we see things going in the future from both clinical and technological perspectives. And of course, we'd love to hear from you too. We'll have a live Q&A session right after the presentations, so please feel free to send in your questions through the platform. Our panelists will do their best to answer with their expertise and experiences. Now, let's move on to the session. Dr. Stefan Dachert will give us an insightful lecture about lung cancer screening experiences in Temple. Dr. Stefan Dachert is a physician researcher at Temple Lung Center who merges rigorous academic research with the real clinical practice to advance therapies for complex lung diseases. His research focuses on lung cancer screening, interstitial lung disease, lung transplantation, and advanced COPD, areas in which he drives innovation and translation into impactful patient care. Specifically, why lung cancer screening is important, why we should do lung cancer screening, and the importance of AI in lung cancer screening in terms of comorbidity detection, especially chronic obstructive pulmonary diseases, interstitial lung abnormality, and coronary artery calcification detection.
Good afternoon, everybody. My name is Steve Dachert. I'm one of the pulmonary and critical care physicians here at the Temple Lung Center at Temple University Hospital here in Philadelphia. Thanks for joining us today, and I hope you enjoy what we have for you today. So today we're going to be talking about the need for smarter lung screening. And again, my name is Steve Dachert, one of the assistant professors here at Temple University Hospital. I have no conflicts of interest with relation to the content being discussed today, and I have no financial disclosures. So before we talk about lung cancer screening, let's talk a little bit about mortality and screening of other types of cancers. So colon cancer specifically, we know that it's the second leading cause of cancer-related death in the United States. Typically, right now, about 72.6% of Americans who are candidates to be screened for colon cancer are actually undergoing screening. Similarly, cervical cancer mortality is about 4,000 patients a year, and we know that about almost 76% of patients that are eligible for screening are up to date with their screening as of 2023. And then finally, breast cancer, about 80% of women who qualify for breast cancer screening with mammography are up to date with their screening as of 2023. So where does lung cancer come and stack up to these other types of cancer? So we know that lung cancer is the leading cause of cancer-related death in the United States, more than colon, breast, and cervical cancer combined. However, only 4.5% of adults who qualified for lung cancer screening back in 2015 were screened. More recently, a study by the American Lung Association estimates that about 5.8% of eligible Americans have been screened. However, there are significant differences geographically in the incidence of screening, with some states with less than 1% of their eligible patients being screened for lung cancer. And so why is screening and early detection important? This slide highlights the importance of early detection. In localized stage, the 5-year survival rate for lung cancer, non-small cell, nears 63%. Diseases with regional lymph node spread brings survival to about 35% at 5 years. And then disease states with distant metastasis, survival is around 7% at 5 years. This is the Temple lung cancer screening cohort data for about the past 4 years. We see a steady increase in patients that are screened every year since inception of our program. And we see that the majority of results fall into the long RADS 1 and 2 category. So what other information can be gathered from low-dose CT? Let's talk a little bit about comorbidity detection. In a recent study published by Morgan et al. In the Annals of the American Thoracic Society, we see a high burden of pulmonary and extrapulmonary comorbidities that were discovered on low-dose screening when performed for lung cancer. Almost 70% of patients undergoing LDCT either had emphysema, airways disease, bronchiectasis, or fibrosis, while 67% of patients had coronary artery calcification or aortic calcification. And there was a significant number of patients with endocrine-related incidental findings as well, most notably thyroid nodules, which was about 3.4%. So let's talk a little bit about comorbidity detection with specifically about COPD. So we know from a study done by Ruparel and colleagues back in 2020, they performed a cross-sectional study of patients undergoing a lung health check in the United Kingdom. Now, in this study, patients underwent LDCT and spirometry at the time of their scan. The results included a total of 560 of their almost 1,000 individuals that had pre-bronchodilator spirometry consistent with COPD. That was about 57% of their whole cohort. Additionally, 67% did not have a prior history of COPD and were termed undiagnosed. So if you look at the cohort as a whole, about 38% of the initial cohort patients eligible for lung cancer screening actually had undiagnosed COPD at the time of screening. So let's talk about the overview on our approach here. So currently at our institution, all non-contrast CT chest scans automatically undergo AI-assisted quantitative analysis by the Coreline AVIEW software at the time that the scan is completed. Analyses that are automatically performed include percentage of emphysema by low attenuation analysis, which is performed at -950 and -910 Hounsfield units, which goes along with the current literature regarding quantitative emphysema. Additionally, we perform analysis for interstitial lung abnormality, which, if you're not familiar with, we'll talk a little bit more about in a few minutes. We automatically perform airway wall thickness, coronary artery calcification scoring, lung texture analysis, and lobar fissure integrity. And reports are generated and populated through PACS, which is the radiology storage system that our university uses. So our approach with LDCT and spirometry. So in addition to the LDCT, we have been performing handheld spirometry to screen for COPD and also measuring fractional excretion of inhaled nitric oxide to measure possible Th2 inflammation in these patients. In this cohort of about 147 patients, 51% had evidence of airflow obstruction, which is higher than outside cohorts, which have recently shown about 33%. Of the entire 147 patient group, about 75% of patients, or 48%, did not have a previous diagnosis of COPD. Of that group, without known COPD, about 50% had evidence of airflow obstruction and symptoms of either breathlessness or cough. Given this, out of a cohort of 147 patients, about 22.4% of patients were discovered to have undiagnosed COPD. Additionally, we noted this group was highly undertreated. Only 2 patients, about 6%, were prescribed dual bronchodilators, and another 2 patients, or 6%, were prescribed triple therapy. Our approach for severe emphysema. So, using quantified emphysema with specific cutoffs and specific patterns, and adding on lower fissure integrity, we attempt to identify patients who may benefit from bronchoscopic lung volume reduction or lung volume reduction surgery. And this is a place where quantitative analysis of emphysema is very important, as strict cutoffs and lower variance play a role in the success of these procedures. And on the right here, we see an example of one of the readouts from or reports generated by the AVIEW software. In addition to the lower volumes, it includes the percent LAA, and also a graphical representation of burden of emphysema. So you can see in this patient here, there is some or a significant upper lobe predominant emphysema as compared to the lower lobes. Additional comorbidities. So we mentioned briefly at the beginning, ILA or interstitial lung abnormality. If you don't know, ILA is a mild or even subtle non-dependent parenchymal abnormality, which affects greater than 5% of a lung zone on CT. And we know that this occurs in about 8 to 9% of heavy smokers. Now, prior studies have shown an association between ILA and both the risk of progression of fibrosis and also worsening pulmonary function in previous large cohorts. So our approach to ILA, as I mentioned, ILA is one of the analyses that's performed automatically on every CT chest here. And so we took a look at about 102 patients that underwent ILA analysis with Coreline AVIEW. We found that 28%, or about 27.5% of patients had significant ILA. Again, that's greater than 5% in one lung zone. And we are with these patients with significant ILA, they're being referred to pulmonary if not already following. Remember that a large number of patients that come into the Healthy Chest, the lung cancer screening program here at Temple, actually referred to by primary care doctors and may not already be following with pulmonologists. Additional comorbidities, coronary artery calcification. We know that this is a marker of atherosclerosis and an independent risk factor for cardiac-related mortality. And so our approach to CAC, so the AI-assisted analysis of CAC calculates an Agatston score, which assesses the patient's risk based on age and burden of coronary artery calcification. And in our program, a high burden of coronary artery calcification triggers a referral to cardiology for possible ischemic evaluation. So in summary, patients at risk for lung cancer are also at risk for COPD, emphysema, interstitial lung disease, cardiac comorbidities, and others. CT analysis platforms, such as Coreline AVIEW, can help identify and quantify the severity of these comorbidities. Coupling LDCT with spirometry into same-day appointments can lead to early diagnosis and treatment of COPD. And finally, utilizing quantitative identification of emphysema, as performed by Coreline AVIEW, can aid in screening patients who may be eligible for advanced procedural treatments, including bronchoscopic lung volume reduction and lung volume reduction surgery. Thank you very much for your time. We'll be seeing each other again for the Q&A session. In the meantime, if you have any questions, please feel free to send me an email. My email is steven.dachert2@tuhs.temple.edu. Thank you very much.
Impressive. It was a great pleasure having you with us, Dr. Dachert. I'd like to say the symbiosis of AI in Temple Lung Center can be better in the perspective of empowering clinicians' capability as well as efficiency. The next session is from the Coreline side. Jiwan Kwak will present Coreline Soft's cutting-edge technology. Jiwan Kwak is the Director of Product Implementation and Client Solutions at Coreline Soft. With over 20 years in the medtech industry, he has extensive experiences in PACS and healthcare IT with a strong focus on clinical integration and data security. He specializes in translating AI technologies into real-world practice to improve workflow efficiency. Jiwan, the stage is all on yours, please.
Thank you, Dr. Zhang, for the kind introduction, and thanks to Dr. Dachert for those valuable insights. Good morning, good afternoon, and good evening to everyone joining us from around the world. I am Kwak from Coreline Soft. Today, I'll share how AVIEW's advanced AI algorithms are powering clinical precision. Clinicians today face substantial challenges: heavy workloads, inconsistent diagnostics, fragmented workflows, and limited insights from traditional chest CT imaging. To genuinely support clinicians, our solutions must deliver four critical strengths: robust AI, proven clinical validation, advanced 3D imaging, and exceptional usability. Let's first clearly understand these practical pain points, then see how our solutions address each. Early detection is crucial in healthcare, but remains challenging. Under heavy workloads, physicians frequently miss small lung nodules, causing delays in critical diagnosis. Current systems often lack structured risk assessment tools physicians need, such as lung RAS or volumetric analysis, making patient management difficult. Moreover, manually tracking patient follow-up scans is fragmented, increasing complexity and risk of oversight. In addition, critical thoracic conditions like COPD and coronary artery disease often coexist with lung cancer, but frequently remain underreported on standard chest CT scans. This connected clinical system further disrupts workflows. To overcome these challenges, our solutions automate precise nodule detections, integrate structured risk models, systematically tracks patient progressions, and analyze multiple critical conditions such as lung nodules, COPD, and coronary artery calciums, all in one scan. Ultimately, this approach improves early detections, streamlines clinical workflows, and significantly enhances patient outcomes. Superior AI performance begins with high-quality data. At Coreline, we've addressed the widespread challenge of insufficient medical imaging data by compiling extensive, diverse datasets from leading global institutions, including Seoul National University Hospital, Assam Medical Center, and major international centers. A reader study at UMMC demonstrated our AI-assisted reading improved lung nodule detections by 34%, significantly reducing misdiagnosis. For COPD, AVIEW achieved impressive accuracy, reducing analysis time by 94%, clearly illustrating how superior AI directly enhances clinical accuracy and efficiency. Powerful AI alone isn't sufficient. Its clinical effectiveness must be continuously proven. After achieving initial FDA clearance for calcium scoring in cardiac gated CT, we recognize the significant potentials of non-gated chest CT scans as well. So we didn't stop at regulatory trials of CAC algorithms for non-gated chest CT. We've consistently pursued rigorous clinical validation studies involving thousands of cases globally, including Korea, Europe, and the East, to continually confirm our solutions' accuracy and reliability. And this commitment to clinical evidence and ongoing validations will continue. Physicians deserve software that naturally fits into their existing workflows. Recognizing this, our team has continually worked alongside physicians to deeply understand their needs. With over 20 years of medical imaging experience, we've prioritized creating intuitive and practical tools, aiming to seamlessly integrate into daily clinical tasks, allowing clinicians to focus more effectively on patient care. Our commitment to clinical excellence is demonstrated worldwide in national lung cancer screening projects. In Korea, through the nationwide lung K-Lucas program, our software serves not just diagnostic purpose, but also as part of comprehensive quality control framework, systematically capturing and evaluating patient data for consistent clinical outcomes. In Germany, our solutions plays a key role in the ongoing Hansen study, which contributed to the national position paper on lung cancer screening. Here, AI enables early detections for both cancer and common comorbidities, reinforcing its essential roles in modern screening practice. The multinational European study, For in the Long Run, demonstrates the comprehensive screening of lung cancer, COPD, and coronary cautions simultaneously, the big three, leveraging AI to streamline initial screenings and effectively rule out negative cases. Lastly, in Italy, our solutions is actively involved with 18 leading hospitals to develop national oncology screening guidelines and workflows. This experience reinforced our visions, delivering comprehensive multi-disease assessments from a single scan. To support this vision, AVIEW LCS Plus evaluates lung nodule, emphysema, and coronary calcium simultaneously from just one low-dose chest CT scan. This integrated approach delivers comprehensive clinical insights quickly and efficiently, transforming a standard chest CT into a high-value diagnostic tool. AVIEW LCS automatically detects lung nodules, accurately measures their volume and growth, including volume doubling time, and supports LungRest 2022. Physicians can easily edit or confirm AI-generated results and swiftly generate structural lung cancer screening reports, streamlining diagnosis and patient communication. Our solution provides variety of outputs. Centric result sheets to detail into existing clinical environments through standard PACS formats like NICOM GSPS, secondary capture, and structure reporting. This means radiologists don't have to disturb their existing workflow to leverage the benefit of AI. AVIEW COPD quantifies emphysema severity using low attenuation area and LAA size analysis, assess small airway disease, and evaluate facial completeness. Recent research published in radiology demonstrate that detailed tracking of emphysema holes, particularly increased diameter holes, effectively predicts disease progression, functional decline, and survival, underscoring their value as objective imaging biomarkers. AVIEW CAC automatically detects and quantifies coronary artery calciums from both cardiac-gated and non-gated low-dose chest CT scans. It segments all four major coronary arteries, providing detailed reports on vessel involvement and calcium severity, meeting CAC-DRS standard. Importantly, recent guideline from ACR recommended routinely reporting coronary calcium findings on low-dose lung cancer screening CTs, emphasizing their prognostic value for cardiovascular disease risk assessment. In the recent For in the Long Run study, a significant Europe lung cancer screening trial actively using AVIEW, AI dramatically reduced negative misclassifications rates from 11.1% by radiologists alone to just 0.8% when assisted by AI. Moreover, AI lowered clinical referral rates and reduced overall radiology workload by over 70%. These findings clearly demonstrates AVIEW's real-world ability to enhance diagnostic safety and significantly streamline clinical workflow efficiency. Our collaboration with Temple Health illustrates the real-world impacting of integrating AI into workflows. By incorporating AVIEW into their chest initiative, Temple has significantly improved early disease detections, streamlined patient care, and increased screening participation. Dr. Criner will share more details shortly. Meanwhile, please scan the QR code shown here to read the full feature in Philadelphia Magazine. Here's an example of the monthly opportunistic screening report that was recently implemented at Temple Health. This concise, actionable report enables nurse navigators to quickly identify key findings, enhancing early disease detections, effective patient management, and improved clinical outcomes. Today, we've explored the clinical evidence and algorithms behind LCS Plus. Looking ahead, we are committed to extracting even more clinical insights from a single low-dose chest CT, covering emphysema, bone mineral density, aortic dimension, ILA, body composition, and beyond, further advancing early detections and comprehensive patient care. Thank you very much for your attention. We are extremely proud of our partnership with Temple Health, and we look forward to continuing our mission to deliver precise and efficient patient care. If you have any questions or wish to explore our solution further, please feel free to reach out. Thank you very much.
I truly believe the quantitative measurement of diseases will we do, not qualitative analysis, will change medicine and save lives. Thank you, Jiwan, for your great presentation. It is time for the climax. Dr. Criner will now talk about Temple's AI-enhanced lung cancer screening program. Dr. Gerard Criner is an internationally recognized pulmonologist and director of the Temple Lung Center. He is a pioneer in translating breakthrough technology and research into transformative clinical care for patients with common to complex lung diseases. His leadership has advanced the use of minimally invasive therapies, AI-enabled diagnostics, and novel interventions for advanced lung diseases, helping shape of the future of pulmonary medicine. The session topics are as follows. First, why we should care about lung cancer, why it matters. Second, introduction to Temple Healthy Chest Initiative system, how they are making the chest healthy. Finally, the AI-based lung cancer screening comorbidities detection will be discussed. Dr. Criner, please.
Hello, and thank you for allowing me to present on the Temple Healthy Chest Initiative, or THCI, and how we use artificial intelligence. My name is Gerard Criner. I'm professor and founding chair of the Department of Thoracic Medicine and Surgery at the Lewis Katz School of Medicine at Temple University in Philadelphia. Lung cancer is the leading cause of cancer death in men and women. One person dies in the U.S. from lung cancer every 4 minutes. That's about 250,000 new cases of lung cancer on an annual basis, and approximately 124,000 patients die on an annual basis. As we all know, the stage at which lung cancer presents significantly affects mortality. As we can see, when the disease is more localized, 5-year survival is tenfold greater than when the disease is more regional or distant in terms of presentation. We now know from 2 large prospective randomized controlled trials that lung cancer screening can improve mortality by 20% from lung cancer when it is detected at an earlier stage. This means that lung cancer screening should be adopted in our practice to try to improve the morbidity and mortality of patients from developing lung cancer at a more advanced stage when very little can be done clinically to treat them successfully. This looks at the lung cancer rates in the state of Pennsylvania, where I reside, and as you can see, the lung cancer case rates are significantly higher than the national average in the state of Pennsylvania. So lung cancer for Pennsylvania residents is a significant problem. However, when we look at our ability to diagnose patients at an earlier stage, we're somewhat limited. About 26% of our cases are caught in an earlier stage, which is not significantly different than a national rate of 25.8%. So we need to do a better job of detecting lung cancer at an earlier stage. We can see that the screening rate of Pennsylvania is about 9%, which puts us in the average tier overall. This is 9% of patients who could be eligible for lung cancer screening. So we need to increase our ability to screen patients at a much higher rate. This is further complicated by under-screening for patients that are male and also of minority. We need to do much better jobs to make lung cancer screening known in the minority populations that we treat and for males. Some of this is because limitations in healthcare disparities based on racial background, but it's also based on the availability of lung cancer screening to fit into patients' work and other issues with their daily living. So what is the Temple Healthy Chest Initiative, or THCI? Our purpose is to expand lung cancer screening to capture all eligible patients and significantly increase the numbers of minority patients that undergo lung cancer screening and have high retention rates for subsequent follow-up imaging. To do this, we employ a multifaceted patient navigation model to track the staging of nodules suspicious for lung cancer that warrant timely intervention for diagnosis and treatment. We also embedded with this a comprehensive program to detect common comorbidities of lung, heart, GI, and musculoskeletal systems that warrant further investigation and try to plug patients seamlessly into other subspecialties to manage comorbidities that are found during the lung cancer screening process. And finally, we embed a virtual and in-person smoking cessation program that is comprehensive and available for all health system patients, regardless of location of care. So how does the THCI program accomplish this? First of all, we have patient engagement. Then we target populations for screen and follow-up for LDCT. We have multiple outpatient locations for THCI assessment and care, multiple locations for low-dose CT scanning, in a decentralized process to facilitate patient engagement, but we have a centralized program for lung nodule assessment and follow-up care. We use integrated AI software programs for lung nodule detection and follow-up, virtual multidisciplinary lung cancer conference, THCI navigators for both screening nodules as well as for incidental nodules that are found on other reasons for chest CT imaging, and we have data entry and schedulers for procedures, outpatient appointments, testing, and follow-up status. We have the assessment of common comorbidities that's in a structured format, and we assess smoking cessation and plug patients into cessation treatment programs. So how do we engage all of our providers in lung cancer screening? Education. We have Zoom conferences for clinicians about the importance of lung cancer screening on a regular basis. We provide easy-to-understand clinical information for clinicians on who to order and how to order LDCT and what to do with the results. And we have CME-approved attendance participation in weekly multidisciplinary lung cancer meetings. We have an Epic portal that we structured for ordering LDCT, multiple locations that are accessible for performance of LDCT. Insurance clearance for LDCT is handled by support staff, and we have same-day, next-day appointments to review patient results. And we have several nurse navigators that are devoted to the THCI program to track patient follow-up and also follow-up of other testing that may be ordered and required. So what do we do on the initial visit for patients for lung cancer screening? We assess for COPD and other comorbidities by using a variety of questionnaires that have been validated for COPD, diabetes, cardiac disorders, and osteoporosis. We perform a pre-bronchodilator spirometry. If patient ends up having significant emphysema, we refer them for pulmonary consultation and lung volumes and the diffusion capacity. If coronary calcium is present, then we order a lipid panel if it hasn't been done before, an EKG, and consider a cardiogram, an echocardiogram if cardiac chamber size is greater than normal. And if there's a history of diabetes or BMI is greater than 30, we order HA1C, and if BMI is greater than 30, suggests a stop-bang questionnaire to be performed to screen for obstructive sleep apnea. And if osteopenia, osteoporosis is present, then we recommend a patient to get a DEXA scan if that has not been ordered clinically. The patients that we screen at high risk for lung cancer with LDCT are, according to guidelines, patients 50 to 80 years of age, current smoker or quit within 15 years, greater than 20-pack year history of smoking, or a patient with a history of COPD. We follow up the results of this chest scan screening, not only for lung nodule, but for the presence of these other comorbid conditions. What do we do with the results of this? If it's a lung RADS 1 to 3, our triage scheme is that if it's lung RADS 1, no nodule, or lung RADS 2, we repeat the low-dose CT scan in 12 months. If it's lung RADS3, probably benign, we repeat the low-dose CT scan in 6 months. What do we do if the lung RADS is 4A or B? We perform a PET scan if the nodule is greater than or equal to 8 millimeters. The patient is referred to a pulmonologist or thoracic surgeon. Consideration for diagnostic biopsy is made, and then the patient's findings are reported to a weekly multidisciplinary lung cancer meeting for consideration for different treatment paradigms. This is our program from inception to date over the last 4 years. We've done 12,584 scans that we've had since we've started the program. And as you can see that we have grown on a significant volume per year over the last several years, with both new patients being screened and then subsequent patients' follow-up scans. We can see in this patient population, which is heavily influenced by our minority patient population that we serve, we have lung RADS 4 in about 4% of our cases to date, which shows that that's a significant volume of patients that we have to be able to triage through our system. If we look at the comorbidities that are found on lung cancer screening, this initial 2,000 patients, we find about 65% of these patients have presence of emphysema, 9% have interstitial lung abnormalities, about 70% have coronary artery calcification, 6% have cardiomegaly, 5% have PA dilation, and a significant number of patients have osteopenia, obesity, aortic calcification. We also find that patients have about 14% have hyperinflation and about 30% have evidence of air trapping, and a significant number of our patients are obstructed. About 63% have evidence of airflow obstruction, of which a significant minority of these patients have severe and very severe airflow obstruction. So how do we use AI in our THCI program? Well, AI overall is increasingly used in chest imaging to identify a wide range of lung abnormalities. And the leverage of advanced algorithms allows AI to enhance both the sensitivity and consistency of detection, supporting radiologists and pulmonary clinicians in comprehensive lung evaluation. These are some specific areas where AI can aid in the detection and quantification of several abnormalities of importance found on lung cancer screening. Obviously, they can look at pulmonary nodules and masses and provide the detection, size, and volumetric sizing, and use this in cancer screening and malignancy risk assessment. It can be helpful in both detecting and quantifying the chronic ILD presence, as well as the percentage of GGOs, as well as fibrotic disease. It can help us in quantifying and detecting the presence of emphysema and airways disease. It can help to determine whether there's evidence of heart failure, volume overload, pleural effusions, lymphadenopathy, which is useful for cancer staging and support, and also the presence of bronchiectasis. So if we look at lung abnormalities or pulmonary nodules by itself, it can detect the size, the shape, the margins, and growth over time, spiculated areas or irregular lesions, solid, subsolid, and ground glass nodules, and then looking at nodule characteristics suggestive of malignancies, such as lobulation or spiculation and pleural retraction. And it can use high-risk scores using radiomics and deep learning models to indicate the likelihood of malignancy and its progression over time. It can also help us change or detection over time by the change in the size and growth pattern of the nodule or its appearance, and it can give us some volume doubling time estimations. This is an example of the AI program that we use, AVIEW, at our institution, where detection of pulmonary size and changes over time can be compared from one film to the other. This is an example of the comorbidities that we find with AI detection. For emphysema, I mentioned we can quantitate the areas of decreased lung density and destruction of alveolar walls, And also, we use it to analyze for fissure integrity if we're considering a lung reduction technique such as endobronchial valve or other forms of bronchoscopic and surgical lung reduction. We also can look at airway lumen size and airway wall thickness and try to exclude those patients for our emphysema treatment and direct those patients or triage them for airway predominant treatments if they have more airway disease than parenchymal emphysematous destruction. And we can also assess vascular structures to determine if we're resecting a portion of the lung or treating a portion of the lung with a lung reduction procedure, selecting the most oligemic area. This is an example of a subject that has emphysema with a history of COPD, and you can see that we can not only detect emphysema, we can quantitate it, we can determine that the left upper lobe has much more in the way of emphysematous destruction. Furthermore, we can look at this and we can look at fissure integrity to determine whether the patient is more likely to be treated in one lobe or one region than the other, as shown here. And finally, we can use these assessment or tools to look at airway wall abnormalities to see if the airway wall is thickened and the lumen size is decreased, and patients may have a more airway predominant than parenchymal destructive process. And finally, this is use of vascular distribution module to try to determine which portion of the lung has more oligemia for deciding whether the patient is going to be resected or treated in that area with a volume reduction procedure. Now, we all know that patients with COPD have a high incidence of coronary artery calcifications and cardiac disease, so we can use the tools to quantitate the Atkinson score and to determine whether the patient is a candidate for lipid-lowering therapy or other diagnostic and treatment modalities for coronary artery disease. The detection and quantification of features like ground glass opacities, reticulations, and honeycombing is also important for us, since about 9% of our patients have evidence of interstitial lung disease, and some of these patients can have combined pulmonary emphysema and fibrosis or other forms of post-inflammatory fibrotic lung disease that could complicate their condition. And this is an example of using our AI software program to detect and quantitate features such as ground glass opacities, reticulations, and honeycombing to give us an aggregate score of the involvement of the patient's lung with these processes. One of the things that's most important for the Temple Healthy Chest program and for a program like this is a creation of a multidisciplinary team that can provide the comprehensive care of the patient undergoing lung cancer screening and comorbidity detection. So, thank you very much for the opportunity to present for the importance of our THCI program and how we use AI to complement our program. Thank you very much.
It was a privilege to learn from your valuable presentation today, Dr. Criner. Thank you very much for your effort and preparation. Now is the time for the faculty panel discussion. The main topics are challenges before AI, multidisciplinary collaboration, real patient case examples, lessons learned, and future vision. Dr. Criner will be the moderator of this session. I'd like to hand it over to Dr. Criner to start the session now. Dr. Criner, please.
Thank you very much. So, Melissa and Steve, what do you guys think are the biggest challenges for others to duplicate what we have in terms of using AI to look at patients for lung cancer screening or for incidental nodule management? Melissa, why don't we start off with you?
I appreciate that. So in regards to AI, I do think that this is a fantastic conjunction along with our radiologists to complement one another so that we can get more accurate detection of any findings. I do think that maybe just making a change, I think, is probably the biggest hurdle to try to incorporate it together. That's from my perspective.
Steve, what do you think from looking at trying to put the data together standpoint?
I think buy-in is one of the most important things, and education of the staff to really pay attention to the AI readouts that the Coreline software generates. I think the more people that are comfortable and understand all the numbers it provides and what that could mean, physiologically, I think that's important to help sort of grow what we can do with the technology.
I guess from your perspective, both you guys, do you think doctors or providers that are using the platform, how much education do you think goes into like learning what to do with the results and how to be able to manipulate the data or guide yourself through the images to use the different tools to assess patients?
I think if you're using the software, I think there is some education to making sure that you're using it properly and you have like the basis, to understand the readouts. But I think the important thing is that AI technology is here and going to be a much greater part of healthcare moving forward. And so utilizing a software specifically the one that we have and that it's relatively user friendly, I think that aids in our ability to help people understand how to use it and to help it grow in the future.
How much skill do you think you need to invest in to really use the AI to identify a nodule, then to make sure that the nodule's not been previously identified or that it indeed is a nodule of concern and just not some other abnormality that pops up with the imaging to justify making the patient do additional tests? How much skill do you think goes into that or time spent?
I think a decent amount of time spent. Certainly we want to avoid unnecessary testing, but being able to track these abnormalities over time and knowing what patterns are more associated with higher risk nodules versus those that are thought to be more benign. I think having a good background in yourself and what these nodules look like, and then comparing it to some of the readouts with interpretation for nodules is important. I think the AI software is very good at identifying nodules, but having a good clinician that's seen enough nodules to be able to confirm that is important. Yeah, that's my thoughts.
Melissa, since our program really capitalizes not only nodule detection and follow-up, but also for incidental findings of other significant comorbidities found on imaging that the AI software helps us to identify, how receptive are patients to that, and how much effort is it for you to coordinate getting follow-up appointments and care for those comorbidities that are found? Do patients identify and appreciate the information, or do they resist somewhat?
No, they absolutely do appreciate it. They are very open to learning, and the key of the navigators is to educate the patient about their findings or providing them their results in a manner that they can understand it. When we ask the comorbidity questions, as you mentioned earlier, that is like the key, like the opening of the door. Sometimes when you see a patient that has moderate or severe coronary calcifications, they haven't had a stress test. So then we ask him additional questions. And then when we just say, well, maybe you should just follow up with a cardiologist, that's when we get them and they say, yeah, why not? Why not do it? Go see a cardiologist. We try to get them in as soon as possible, not pressuring them, but scheduling is very easy. Within 24 hours, the patient will receive a phone call to schedule a new patient appointment to any of our specialists at Temple. So they're very receptive.
And just to add to that, I think I agree with you 100%. The beauty of the cancer screening tool that we use to detect lung cancer is that it's a CAT scan, and it by its nature delivers us a lot of extra information. Folks that undergo mammography don't have that ability. Folks that even undergo colonoscopy don't have that ability. But we're able to see abnormalities in obviously lungs, but cardiac, as we've mentioned, other large great vessels in the chest, and also things like obesity and bone density. So, we're at the point right now where this is a wealth of information, and if we solely use it to identify lung nodules, I think we're doing patients a disservice. And that's why I think it's so important that we focus on these comorbidities, and as Melissa said, getting folks evaluated by the proper folks for these comorbidities.
So you bring up a good point, Steve, and maybe both of you guys can address it, that you're generating a lot more data. So how do you manage the data so that it's collected, it's acted on, and there's like 360 follow-up with the patient and an action plan to get it done? What are your tips to do this, and what would you need to make it even better? So maybe you first, Melissa, because there's a lot of data that you're generating.
Thanks. Yeah. So yes, currently our data is being captured in what we call RedCap. That was created by one of our navigators to collect all this data. I do think that although it's a tool that we're using at this present moment, I believe that this program definitely needs a navigational program that's solely dedicated to screening not for LDCTs as well as any other incidentals or these other CTs that are being completed to capture these nodules, and particularly the ones in the chest, right? But following up on every month or every 3 months, as we do here at Temple, to see who's due for a follow-up in 6 months, as well as the annual LDCTs that patients are due. We run that report every 3 months so that we can make sure that we remind these patients that they're coming up due for their annual screening. And the good part of this program is that now we have a dedicated APP who enters these orders. Well, the navigators enter the orders, the APP sign it off, and the patient already for the following year has an LDCT ordered. So our schedulers from Temple will contact them to schedule their annual LDCT. So I think that, again, the biggest component is to have a program that can capture all that data and make it easier for the navigational portion.
Steve, what do you think?
Yeah, I think the beauty of collecting all this data and all these variables is that we can use that data to help isolate patients who might benefit from additional treatments. I know you mentioned in your talk, I think I mentioned it in mine, the ability to screen severities of emphysema and certain patterns to see, to grab these patients out of the mix and say, this is a group of patients that may not have ever even seen a pulmonologist, but may actually benefit from these additional procedural interventions. And when you have a large amount of data with a large amount of variables, you have that ability to pick those patients out and give them the extra help they need. So I think the ability to create a database that can house these variables and this data and to be able to easily use it and identify it is key. And we've used RedCap here. I know we're currently in talks with the provider of our AI system to help actually talk to RedCap, and that's, I know, something that the developers are working on to make our inputs even easier.
Okay. There's some questions in the chat. Melissa, I'll give this to you. How is our patient population for low-dose CT scan classified according to gender and racial distribution?
For accurate numbers, I would have to go back and check, but I believe that our sole focus is to focus on our minority groups, so our Blacks, African American, or Hispanic community, to try to get the increase of low-dose CAT scans being completed. But again, don't have the accurate number, but yes, that is our solely focus, is to get the minority group to have their LDCTs completed.
Yeah, I'll weigh in a little bit. From the last data, from my memory that you provided, we have about 54% are women, and the rest are obviously males. And if we look at the minority group, I believe we're about 42% African American and about 15 to 18% Hispanic, and the rest are Caucasian. There might be 1% that's other, that's not classified. But just as Melissa said, we really developed this program in response to the USPSTF last recommendation and really tried to increase our minority for women and for minorities based on increasing the availability of our program and basically shared decision making and basically using communication with our population health programs to try to capture those patient groups and make them aware of the opportunity of lung cancer screening. Steve, do you want to comment any further about our demographics for our program and our attempts?
Actually, I happen to have the numbers here if we can go through them really quick. So it looks as though we looked at the first year of our study in great detail, and I remember, and I have it here somewhere. Here we go. The percentage of patients that self-identify as Black or African American was about 40%. Patients that identify as white or Caucasian was 34%, and then Hispanic patients in this group were about 18%. And I remember, as we went through this data, one of the really striking things that we found was that we found significantly greater severity of emphysema in minority patients, including Black patients and Hispanic patients, who actually had smoked less pack years of cigarettes than their white counterparts. And so, that's something that when we went back and looked at the data, we thought that this was sort of a gap in research knowledge and something that we looked further into. So, that is an additional benefit. In addition to giving patients the extra benefit that they get from having their CAT scans identified or looked through by AI software. When we get these large data sets, we look at trends and we look at how certain patient groups may be acting and responding different to cigarettes or even other treatments. So I think it's important.
So there's another question from the chat. I'm going to have my idea, but I want to hear yours first. If you had to pick one aspect of the AI program, what do you think is the most helpful?
It's a good question. I think to me, it's identification of emphysema, because, and when I say identification, what I really mean is quantifying it, right? When radiologists look at CAT scans and LDCTs, it's very frequent that they mention that there's emphysema. And as I looked at that first year of data that we have, there was a large amount of patients that had the radiology review mentioned that there was emphysema, but it wasn't further quantified. And when we ran those patients through the AI software, we were able to pick out some patients with very severe emphysema. And, when you identify emphysema of certain, severity, we know that those patients should see a pulmonologist, and that drives the care forward. It drives further treatment, diagnosis of COPD, further testing, and then treatment. So emphysema for me, but see what you think. Well, I'm interested to hear your thoughts.
Melissa, for you, what do you think?
I think from a navigator's point of view is just the diagnosis or just being the accuracy of descriptions of the results. And that helps us then to relate to the patient. So I think that would be it. That's the key.
Well, for me, it's a couple things. One, it's the immediacy of the report because it's integrated into our chest imaging for all patients getting chest imaging. And it's the comprehensive ability to quantitate many things, like Steve mentioned, the emphysema or ILA, and speciate the ILA into either ground glass opacities or fibrotic phase, the vascular density, the coronary artery calcification, and not only the quantitation of the emphysema, but fissure integrity and hole size. Having that together as an aggregate, the more comprehensive quantitation of the imaging data complements the qualitative reports that we do as pulmonologists as well as our thoracic radiologists. So I just think it makes all of us better and provides a better assessment of the patient's lung nodule or presence of lung cancer, but also the other features that go into their disorders. So to me, it's the whole thing that really helps the most, and the immediacy of it. There's another question from the chat. How do your radiologists perceive working with this information? Melissa or Steve, do you want to comment?
I think, Steve, you can take that one.
Sure. I think they work in parallel to it. although I don't spend a lot of time in the radiology room, I think they continue to interpret CTs with, the level of detail that they always have had, which is great. And, we certainly don't want them to spend less time looking at the scans just because they're running through AI. And so, I think and I haven't perceived a change in how radiologists are interpreting these scans. So I think right now, they're working with it, and that's sort of where we are.
Yeah, I want to put a plug in for our thoracic radiologists. They helped us to semi-quantitate other comorbidities that currently aren't identified in our software program. And as Steve said, they work in an integrated fashion with the AI and help to complement that. So I commend them, and I think it's a good tool for all of us to use. Melissa, when you talk to patients about the results of the information, how much do you communicate to them that we're looking at comorbidities? And do you mention anything specifically about AI programs helping us to communicate the results or identify the results to identify to the patients, or how do you do that?
So at the current time, I haven't mentioned to the patients that we're currently using AI. That is something new that I would like to probably incorporate and mention to them. But when we go through the review of the results, we thoroughly go over the results in a format that they understand systemically, and as well as when we go through the questionnaires, the comorbidity questionnaires. So that is also systemically, and then we can gather additional information. But that is something that we definitely should be incorporating in our conversations with patients, is that we're using AI to help support the results.
I don't know about. Go ahead, Steve.
When I see patients in clinic and we discuss, the pros and cons of lung cancer screening with LDCT, I talk about the AI assistance software, and I think it helps. I think the response I've gotten from patients is that they're happy that obviously a radiologist is interpreting these scans, but also that there's additional technology interpreting these scans. And one thing that I've also found is that when I go through results, I will show folks the readouts from these, and knowing that you have emphysema is different than seeing it quantitated in front of you in the outputs that the software gives you. And, I've had patients who I've been trying to get quit smoking for years, and I show them the extent of their emphysema, and they said, they've told me, wow, I did not know it was that severe, and, I need to make a change. And so I have found that bringing it up in clinic and having the conversation about AI has helped.
Yeah. I would agree with Steve. I do the same thing in clinic. I show the patients both a qualitative and quantitative view. I put it in their Epic note, their medical record, and send it not only to the patient, but to the referring physician. And I agree that patients wholeheartedly, when they look at the picture and see it, they understand better than any kind of word information that I would give them. So I think it's a nice help. I think that's about all the questions in the chat that we haven't answered. I'll give a last round for you guys to make any further final comments or questions that you might have, Melissa or Steve.
I think I've really enjoyed using this technology. I've really enjoyed looking at the large data sets that we've been able to accumulate, and looking at trends in a patient group that has been relatively understudied for a long time, right? If you look at the large lung cancer screening trials, they are very, very much white patients and very, very much male patients, and that is very much not the patients we treat here. And so I think it's been an invaluable tool to help us figure out and identify trends in patients with pulmonary comorbidities, the ones that we treat. And then, so that's sort of the population level. And on the personal level, like we talked about before, being able to show patients exactly like a graphical representation of what's going on in their lungs, it really helps patients understand, and really strengthens the physician patient, covenant there. And I'm very glad that we've been able to use this technology.
For you, Melissa?
I think for myself, I'd like to dive in deeper with this program so that I can understand it more, and then try to see how I can then explain it to patients, how we're incorporating it into our lung cancer screening program.
Okay, well, there's two more questions, but they're for our Coreline colleagues. I guess for whoever wants to address this one, Are there plans from a Coreline perspective to expand the software capabilities to include other imaging types or predictive risk models? Do you want to take that one first?
Yeah, I'd like to take them once. So actually, we are under consideration of developing like risk models and like malignancy score. We are very onto that, but I think we have to make a model that can change the real clinical practice. So not just making a model just itself, but we have to think about whether this model can change the clinical routine practice or not. So I think in that case, we can make a risk prediction model or maybe a malignancy model, progression model, whatever it is. But if it doesn't change the clinician's practice, I don't think that it is our goal. I have to say like that.
And I guess, Dr. Jang, a follow-up with that would be, what lessons did you learn about implementing the system at Temple that could help other healthcare systems adopt AI technology?
Yeah, that is a very interesting question, but I want to reverse the question. So, what were the main hurdles in Temple to adopt the AI system in your hospital? I'm just curious about that.
For me, it was getting IT support and approval to integrate it against, the concerns about firewalls and things like that. So it was really the integration to the technology, not so much the acceptance of physicians or its use. Steve or Melissa,
Sharing.
any other comments about that? Challenges?
No, I mean from my perspective, I've always been able to, the software's always worked for me. And we have the option of using it remotely as well, which has helped on occasions. I wasn't part of the implementation process, but from a user perspective, I truthfully have not had any issues with it.
Good. How about you, Melissa?
Oops. I haven't had too much of experience with it, but again, I'd like to know more about it so that I can share it with the patients how we're using
Good.
it.
Great. Anyone else have any comments or questions before we close? Well, great. I want to thank you, Melissa, Steve, and Dr. Jang for allowing us to present with you today, and I hope this was helpful for people. And if there's any questions for us later on, we'd be happy to answer them. Kelly Flynn will help to coordinate us, and we'll respond back to you. But for everyone who's been involved with this, thanks very much, and have a nice rest of your day. Bye-bye.
Thank you very much.
Yeah, thank
Yep.
you. And I'd
Thanks
like to
all.
wrap things up. So, yeah, it's time to close this webinar. So, yeah, I really appreciate the presentation discussions from Temple and Coreline's side and insightful questions from the audience as well. If you have any questions or willing to contact us, please feel free to contact us with the following QR codes. Thanks to everyone who made this event and joined this event. Thank you.